Yeah, I've been talking speaking earlier about alcohol and how we treat the disease with from a medical perspective, but also a counseling perspective. But that also holds true when we're dealing with opioid use disorders. If people simply go cold turkey, they can succeed, but the success rate at 1 year is only about 15%. If we use medication assisted therapy or MAT, we can get those numbers up to about 40%. And then hopefully, with uh, very well designed programs, we can do better than that. But the opioid receptors are used to being accessed on a regular basis, and when those receptors are now barren, it's going to subject people to cravings, triggers, and also a lot of the psychological or psychiatric issues that either preceded the addiction or are now present because of the trauma and stress from the addiction itself. But what we use for the when people are coming off are primarily two things. One is called buprenorphine, and the trade name when you make a buprenorphine naltrexone film is Suboxone. But for Suboxone, it's a partial agonist, and a partial agonist, if people are at 100 with heroin, it's going to bring you down to 60 or 70. And you can't, no matter how much you use, you can't get past 60 to 70. What we're doing is we're not trying to help people get high or have people on a substitute addiction. What we need to do is we're trying to get a medical handle on that person in the sense that we want the cravings to be minimalized. We want some help with triggers, and we have to stabilize that patient. And this is a medical, in my mind, a medical treatment for a medical disease. Now, with something like that, we're going to have to wean that with time, and that can be a tough wean. So it's not nothing. We respect buprenorphine, and but on the other hand, the most important thing to me when I see a patient is I do not want that patient to go out and overdose on fentanyl. And if I can prevent that or try to get that patient in a better mindset for counseling, that's where I want to be. And all these decisions are made in conjunction with the patient. I believe that the patient makes a decision, I educate the patient. And so ultimately, what's right for a patient, for one patient, may not be right for another patient. Methadone is another modality that's a full agonist, so that'll keep you right back at 100 out of, like when I said buprenorphine was 60 or 70. But methadone, they do have good results because methadone clinics are very regimented. The negative thing about methadone is that it's a particularly dangerous drug, and it accounts for a disproportionate amount of therapeutic deaths when it's compared to other narcotics that are prescribed. Number one, like respiratory depression far exceeds analgesia, so people will have respiratory suppression and they don't even know the drug's on board. But if you take another product in that window, that could be lethal. Cardiac arrhythmias, funny heart rhythms, are definitely a possibility, and people should have an EKG to check for a prolonged QT interval with methadone, and that's important. But it also, for long-term use, I don't want to be negative about anything, but you look at the positives of, again, what we're trying to do is make sure when the patient comes to me that person's alive in 12 months. That's my primary goal. And then how I get to it is going to be, personalized to the patient. But osteoporosis can happen with long-term use, and also elevated prolactin levels. And prolactin elevation can lead to sexual dysfunction. And one of the things in recovery is having a relationship and the ability to live a normal life is very important to recovery. The other product is the blocker, naltrexone, and naltrexone can be given as pills, or Vivitrol is a depot formulation of the blocking agent. Now, what that does is if you can override naltrexone if you take enough narcotics, but you have to take a lot. And that taking that much can be really very, very dangerous. But at least you have that, if you're on the trapeze, you have that net, and the net's saying, like, if you want to, you want to, you want to, even if you use narcotics, you're not going to feel it. It's just going to be blocked. And so, but it doesn't help with the cravings. Although with time, if you know that you can't use opioids, then maybe the cravings will dissipate naturally, because the fact that you know that even if I use, it's simply not going to get the effect that I want. The thing that I always worry about with Vivitrol, to a certain degree, and with other products too, is we got to be really careful so that there doesn't become a new product that gets introduced that becomes a new source of addiction, because it doesn't block alcohol, it doesn't block cocaine, it doesn't block methamphetamines, so it just blocks opioids.